Today we are going to be looking at the structures inside the retroperitoneum and how exactly they are arranged in relation to each other. Now, all of these structures may not be exactly the way that they are inside the body, and we are really not looking at giving a complete overview of each and every structure inside the retroperitoneum. But what we are more concerned with is the fact that there are some structures which we have to know as clinicians and as surgeons in order to be able to perform surgery effectively. So we are going to deal with some of the basic structures that we find over there in the retroperitoneum rather than have a complete overview. And of course, those of you who are interested can do some further reading from certain books, which I will tell you or recommend at the end of this session. So the entire dissection of the retroperitoneum and all its concepts start basically at the level of the sacral promontory. So if this is the sacral promontory, we can say that this is probably the right side and this is the left side. Okay. So here is the sacral promontory in the center, and all the dissection, all the structures that you want, everything is going to be in relation to all of this. So let's see how this works out. First of all, let us take the most constant structure that we are concerned with. If this is the sacral promontory, then let us assume that the uterus is over here like this in the center. So I'm going to draw the uterus over here. This is the cervix, and these are the two uterosacral ligaments. Okay, so I'm going to make them a little dark black for understanding. And then of course the tube and the ovary over here, and similarly on the other side. So for ease of drawing, we are only going to show one side now, but then it is going to be the same on the other side, and that I'm sure you can extrapolate. So this is the uterus and the uterosacral ligaments, and here I'm going to draw the anterior abdominal wall. So that's roughly how the structures are going to pan out. Now on one side, so first let us look at what happens to the vessels which we are going to deal with. So the first structure that we ought to know, and we'll start again from the sacral promontory, is the abdominal aorta. So this aorta lies in the center, and we all know that it is going to bifurcate at the level of the promontory into its right and left branches, and these right and left branches are going to be known as the right common iliac and the left common iliac. Okay, the right common iliac and the left common iliac. This is the right one and this is the left one. Now once the common iliac arteries have emerged, they are going to split into the external iliac and the internal iliac. So the external iliac artery is going to go outwards like this, and the internal iliac artery is more or less going to go straight like this. Okay, so that is a specific difference between the two, that the internal iliac is going to go straight and the external iliac is going to go on the side over the pelvic side wall. Okay, so this forms the external iliac artery and this forms the internal iliac artery, which is running this way. Now let us see what happens to the vein. So we'll complete the venous part over here and then we'll move on again. So if we look at the vein, then the vein over here obviously is we all know this is the inferior vena cava. So the inferior vena cava is over here on this side. Now what is important to know is that the inferior vena cava is to the right of the aorta and is situated a little bit posteriorly. So you can say that the IVC is posterolateral to some extent to the aorta. And why this is important for us to know? For the simple reason that when you are doing a dissection or when you are doing a para-aortic dissection, or even looking at the structures, or let us forget that, even when you are putting in a primary trocar, you have to be more careful on the right hand side, because to the right of the midline you will get the IVC. So this is the inferior vena cava. Now before we look at how these structures go, the vessels go out ahead, let us look at what we actually get during dissection of the lateral pelvic wall. Okay, so you all know that the peritoneum forms like a covering on the entire all the structures in the peritoneal cavity. So when you actually start dissecting the lateral pelvic wall, the structure that you generally find, which is the most lateral structure after the peritoneum etc. has been exposed, is a muscle. Okay, and this muscle is the psoas muscle, or you can call it as the psoas major. I'll just write that down here. So lateral most you will get the psoas major muscle. Okay, I'm just going to leave the labeling there because otherwise a lot of space will be wasted. So this is the psoas major muscle. Okay, consistently on the belly of the psoas major muscle one finds a nerve. Okay, so this nerve runs over here on the belly of the muscle, and this is the genitofemoral nerve. This is the genitofemoral nerve. So this is also seen consistently over the belly of the muscle. Then once the psoas major muscle and the external iliac artery, the genitofemoral nerve are seen, when you start dissecting more and more medially, then the first structure that you are going to encounter, or rather see even in the undissected peritoneum, is actually the external iliac artery itself. So the external iliac artery is going to kind of run like this. Okay, these diagrams are not to scale, they are just for the intended for the sake of teaching. So the external iliac artery is going to run this way, medial to the psoas major muscle and medial to the genitofemoral nerve. I'll just make this a little bit more smooth so that it is easier for you to understand. Okay, so this is the external iliac artery, and you can see that it is going to run like this and go forward. Similarly run like this and go forward. Okay, so this is the external iliac artery which you are going to get over the pelvic side wall. Now near the external iliac artery you also get one more consistent structure, which is the external iliac vein. Okay, the external iliac vein will come over here, and the external iliac vein is important for us from the dissection point of view, because the external iliac vein, like here we told the relation of the inferior vena cava, the external iliac vein is also slightly posterior and medial to the external iliac artery. The significance here is that when you are doing lymph node dissection and you have got these lymph nodes which are to be dissected in cases of CA endometrium, then it is possible that while dissecting between the two you may damage it, particularly because these lymph nodes lie between the two structures and there is always some or the other covering of fat which is there over the external iliac vein. So this external iliac vein may not be seen as clearly as the external iliac artery. Again, an arterial damage is easier to manage than a venous damage, and most pelvic surgeons who do advanced surgery will be dreadful of a damage to the external iliac vein rather than the external iliac artery. So posteromedial to the external iliac artery and running straight along its course is going to be the external iliac vein, which you have to watch out for when you are doing the dissection. Now comes the remainder of the external iliac artery. So the external iliac artery is going to course anteriorly in the pelvis like this, and it is going to go up till here. And what are the branches of the external iliac artery inside the pelvis? The best thing is that the external iliac artery has got no major medial branches at all inside the pelvis, and that is the reason why we are able to dissect easily between the external iliac artery and the external iliac vein while doing radical surgery. So it has got no major medial branches inside the pelvis that the surgeon should be aware of. If you read anatomy textbooks, there are more branches, etc. But that is not important for us at this point of time, because as surgeons, we are not really concerned with the problems that it is going to come up with. And then the external iliac artery will end here by giving some superficial branches like the circumflex branch, and it will give the inferior epigastric artery, which is sometimes a problem for us because it causes the bleeding over the abdominal wall. And this is the circumflex branch, and there is, I think, another superficial branch as well, but that is not really for our understanding purpose. So as far as we are concerned, in the pelvis, the external iliac artery really does not have any significant branches that we should be bothered about as clinicians. Now let us shift our focus to the main one, which is the internal iliac artery. In the internal iliac artery, one consistent thing that you have to remember is that like the aorta immediately branches off into its right and left branches, the internal iliac artery also runs a very short course. And after running that short course, it immediately gives off one division, which is called as the posterior division. Okay, so this is the posterior division. And then what continues anteriorly is called as the anterior division. Okay, so I'm writing PD and AD for posterior division and anterior division. Maybe I will just shift the labeling to the other side so that it is more comfortable for you to read. So again, this is the internal iliac artery, this one. So I'll write it down as internal iliac artery. And this one is the anterior division of the internal iliac artery. Okay. Now the posterior division is significant for us. Significant one, because it arises posteriorly and it courses in and gives off some branches. So if you look at what are the branches of the posterior division, the branches of the posterior division are mainly the superior gluteal artery, the iliolumbar artery, and the lateral sacral artery. And for us, it is the superior gluteal which is quite significant, for the simple reason that this goes and supplies the muscles of the thigh. That is why when you perform internal iliac ligation, you are always instructed that you do not perform internal iliac ligation exactly where the internal iliac originates. Even if you can leave out a centimeter or two of the internal iliac artery, you do not even have to check where the posterior division is originating from. It will automatically go away and it will not hamper you at all. However, if by any stroke of bad luck you perform the internal iliac ligation earlier, that means you perform the internal iliac ligation at this level, then you are also compromising on the posterior division blood supply, and that means you will have necrosis of the superior gluteal muscles, and that will become very bad for the patient. So this is not allowed. And most of the times, even if you wish to do it, it is not possible to do it accidentally, because the posterior division immediately leaves and is not accessible to a standard skilled operating surgeon. For somebody with fantastic skills, they can demonstrate the posterior division, but generally not possible for a standard skilled surgeon. Now we go to the remainder, which is the anterior division of the internal iliac artery. Now the anterior division of the internal iliac artery courses straight, okay, and then it will give off its first medial branch, and the first medial branch is the one that we are concerned with the most, and this first medial branch is the uterine artery. Okay, so the first medial branch of the anterior division of the internal iliac is the uterine artery. Once it has given off the uterine artery, it courses further. Okay, it courses further, and the second medial branch it gives out is something that will supply this area. And what is there in this area? It is nothing but the bladder. And so the second medial branch is the superior vesical artery. And here, of course, you are going to get the bladder. So I can just draw the bladder over here, and this is going to be the superior vesical artery. Now this is significant for us because when you are going to do the dissection, at that time you will see that that you have to do to find out the uterine artery is to dissect in straight parallel to the internal iliac artery and between the ureter. I am going to draw the ureter in a short while, but you just have to dissect straight, and the first medial branch which is going to block your movement forward, as Dr. Shailesh Puntambekar has described fantastically in his book of anatomy, is the uterine artery. And then this uterine artery is the most consistent medial branch, so that makes it easier for you to find the uterine artery. Conversely, suppose you cannot find the uterine artery, sometimes you have to go forward. So let us see how this goes forward after giving the superior vesicle. After giving the superior vesicle, this goes and attaches to the abdominal wall. Okay, but by this time it does not really have any blood within it, so maybe I will draw it in a different color like this, and this by this time it has probably become non-functional or obliterated, and hence the name obliterated hypogastric artery, also known as the medial umbilical ligament. Not the median. The median umbilical ligament is here, the remnant of the urachus, but this is the medial umbilical ligament, and the medial umbilical ligament actually forms the lateral boundary of dissection of the bladder. So when you have to do a dissection in the retropubic space, then these two medial umbilical ligaments over here and over here are going to be the end points of your surgery for dissection, beyond which you do not need to venture. So this is the importance of the medial umbilical ligament. The other importance is sometimes you are just not able to find the uterine artery, and then using the obliterated hypogastric artery, because the obliterated hypogastric artery is seen as a surface marking over the peritoneum as the medial umbilical ligament. There is a video also to this, and if you pull the medial umbilical ligament under the cover of the peritoneum, you find that you are able to trace your way back to find the superior vesical artery and then the uterine artery. So this serves a purpose of helping us find the uterine artery also by way of retrograde dissection. So these are the two uses of the medial umbilical ligament. Okay, and now we will come to the one of the most important structures that we need to know, and that structure is the ureter. So I'm going to take away a little bit of these markings in order to make some room for the ureter. So maybe this one I will take it away, and this one I will take it away, so that the ureter can come inside here easily. Okay, so now there is of course ureter on both the sides, and before the pelvic brim it is an abdominal organ, and at the pelvic brim it is going to cross from the lateral side to the medial side, and this is going to be same on both the sides. It's going to cross from the lateral side to the medial side. However, what happens is on the right side the ureter crosses into the pelvic brim at the bifurcation of the common iliac, where it bifurcates into the external iliac and the internal iliac. And what happens on the left side, which is a little different, is that this crossing over in case of the left side happens above the level of the bifurcation. Okay, so on the right side it is at the level of the bifurcation, and on the left side it is above the level of the bifurcation that this happens. So on the right side it is at the level of the bifurcation, and on the left side it is above the level of the bifurcation. I personally like to remember this as lab rat, so I am able to remember it very well. Okay, then what happens? The ureter courses straight after crossing medially. It courses straight, and now it is coursing in the medial leaf of the broad ligament. Okay, we'll talk about the broad ligament later, but as of now you can remember that it courses straight and it is going parallel and medial to the internal iliac artery. So it is going parallel. I'll just label this again for your convenience. We had said that this is the anterior division of the internal iliac artery. So this ureter is going parallel and medial to the anterior division of the internal iliac artery. Okay, and it continues to go forward till it reaches the uterine artery. Once it reaches the uterine artery, it passes through a fascial tunnel. Maybe I'll draw this in another color. It passes through a fascial tunnel over here, and the ureter disappears. And where does it disappear? Where it is actually going is, it is going underneath the uterine artery, okay, underneath the uterine artery, over the lateral fornix, and then finding its way into the bladder. So this is not exactly to scale, but you get the picture. So the point to note over here is, this is the position where you get the water under the bridge. And this portion of the dissection is also called as the tunnel of Wertheim's, which is the most important point of dissection in cases of radical hysterectomy for CA cervix, because unless you deal with the ureter and lateralize it in the tunnel of Wertheim's, you cannot take away significant part of the parametrium, which has to be excised in cases of CA cervix. Okay, so that is the importance of the tunnel of Wertheim's and the relation of the ureter with the uterine artery in the tunnel of Wertheim's. Now coming to the safety margins that we have to employ. Now here let us say that this is the ureter which has crossed over on the inside, and we are looking at probable areas where the ureter can get damaged. So in order to explain this, if I am going to draw the peritoneum, I am going to take the golden color over here now, and I am going to draw the peritoneum. So the peritoneum, so again this is not to scale, so exactly you will not understand, but peritoneum is draped over all of this, kind of like this. So the peritoneum is draped over all these structures like this. So if you have got the round ligament, the fallopian tube, so let's say this is the round ligament, the fallopian tube, this is the round ligament, and this is the tubo-ovarian ligament. Then the entire peritoneum which is there is going to be draped over this like a cloth that is put over various structures, and all of these structures are lying underneath the peritoneal cavity. So if you remember your anatomy textbooks, they used to give a cross section of this, and the cross section used to be seen like this, and this would be the peritoneum which is draped over it. Okay, so like this. So this peritoneum is draped over it, and all the other containing structures, inside structures, are all located here within the drape of the peritoneal fold. So now when we look at this kind of structure, what we understand is the peritoneum which gets draped over the broad ligament essentially gets two leaves of broad ligament. Okay, this one can be called as the posterior leaf of broad ligament, posterior leaf, and this one can be called as the anterior leaf because they are posterior and anterior. Alternately, you could also call the posterior leaf as the medial leaf of the broad ligament, and the anterior leaf could also be called as the lateral leaf of the broad ligament. The point I am trying to make is, whatever happens, the ureter always and always courses. Unless you have dissected it away, the ureter is always going to course in the posterior leaf of the broad ligament. And hence, if the broad ligament is like this, when you open the broad ligament, you just have to push the posterior leaf of broad ligament down. I will explain this in another video later on, but you just have to push the posterior leaf of broad ligament down in order to safeguard the ureter. So when at this stage, here at the ovary, when this is, for example, if this is the infundibulopelvic ligament which is running like this over here, and this is the posterior leaf of the broad ligament over here, and the ureter is running below this like this, then all that the surgeon has to do is to take an incision over here, okay, and push the posterior leaf of the broad ligament down, so that automatically the ureter gets safeguarded and comes out of harm's way. We will have another video posted on this shortly, but you can remember this much for now. The second place where it may get damaged, the ureter, is here at the tunnel of Wertheim's. And here one more important anatomical landmark that you have to remember is that close to this uterine artery, obviously you will also have the uterine vein. Okay, so this is the superficial uterine vein, and it will also drain into the, like this is the uterine artery, there will be a uterine venous drainage over here. Okay, more technical details you can skip, but all that you have to actually remember is that the ureter lies at this point in the fork between the artery and the vein. This again has been beautifully described by Dr. Pontambekar in his textbook. And if I were to just draw this again, if the vein is like this and the artery is like this, then the ureter is going to course like this in the fork between the artery and the vein. Okay, so it is going to be like this. That means if you look at the relations of the two, the vein is always going to be under the ureter and the artery is going to be over the ureter, and then this continues like this, for example. When we have understood this relation of the two structures, then this is very useful for us in terms of safeguarding the ureter. While dissecting at this point, suppose there is an injury and there is bleeding which comes from here. All that you have to do is identify whether the bleeding is from the vein or the bleeding is from the artery. Because an arterial bleeding, you know, is always going to be a spurt, and a venous bleeding is always going to be a slow ooze. So identify whether the bleeding is from the artery or from the vein. And accordingly, if the bleeding is from the vein, what you have to do is with your grasper, you will have to lift up the ureter upwards and then cauterize the vein. And if it is arterial bleeding, then with the grasper, you will have to depress the ureter down and cauterize the artery. And this is again, I gave my reference to Dr. Shailesh Puntambekar's book, in which this is all shown as live surgical diagrams, and those of you who are interested in this anatomy must read that book definitely. So this is how the arrangement of the ureter and the great vessels is. And before we conclude, one more thing that needs to be discussed is the rectum, because nowadays there is a lot of literature coming around regarding deep infiltrating endometriosis surgeries, and there are some specific things that you should know as regards these surgeries and what is the anatomy of this particular area. So I am going to take away some of the structures on this side in order to make some room, and we are going to draw the bowel coming in over here. So in fact I can get rid of this as well. Right. So now we have the bowel which is coming in over here, and we can say that it is probably placed like this. So this would be the rectum over here. Okay. And usually we know that in endometriosis there is a rectal nodule which causes tenting up of the rectum, and it makes it difficult for the surgeon to operate. So somewhere here maybe there is something like a rectovaginal nodule or a rectal nodule, and this has to be dissected away in cases of endometriosis. Now for doing this particular dissection, we require to singularly separate the rectum from all these structures that are there around it, and so what we do is dissection of the pararectal space. And this is the dissection that we are going to talk about now. So in the dissection of the pararectal space, some of the spaces are already very well known to you. You already know of the uterovesical space, which you dissect for each and every hysterectomy, which is anterior to the uterus, and that space is over here. So that space is in here. You also dissect the rectovaginal space, which is the pouch of Douglas, which is over here. Then you have the paravesical spaces, which are located on the two sides of the bladder. So that's 4. And then you have the two pararectal spaces, which are located on the two sides of the rectum. Now the paravesical spaces and pararectal, all of these spaces are imaginary, and actually these have been divided by us for the sake of our understanding. but these spaces are connected to each other, and the thing which is dividing the pararectal space from the paravesical space is actually the uterine artery. So once the uterine artery has been cut, then the paravesical space and the pararectal space, they join and form a single unit. But till then, these two are separated by the uterine artery. Now, this is the ureter. I already told you it is coursing here in the pararectal space, and by virtue of this ureter being here, we are able to divide the pararectal space into two parts. Okay, so if this is the entire pararectal space in this much area, I'm not coloring this now, but if this is the entire pararectal space next to the rectum, then it can be divided into two parts. This is the medial part, or the medial pararectal space, and this would be the lateral part, which I may call as this one, lateral to the ureter, which I may call as the lateral pararectal space. These two spaces also have names, sometimes asked in exams, important to know for surgeons who are dissecting. So the medial pararectal space is called as the Okabayashi space. It's a mouthful of a name, but very important. The Okabayashi space. Okay. And the lateral pararectal space is easy to remember, L for lateral and L for Latsko. So the lateral pararectal space is called as the Latsko space, and the medial pararectal space is called as the Okabayashi space. One last point to remember anatomically before we go forward is that there are some contents in these spaces which are important. So in the lateral pararectal space, of course, we will continue to do the dissection of the lateral pararectal space. So that means we will continue to dissect parallel and lateral to the ureter when we are looking for the uterine artery, because the uterine artery is going to be found lateral to the ureter, and you have to do dissection between the ureter and the anterior division of the internal iliac artery. Okay, so when you dissect between the ureter and the anterior division of the internal iliac artery, you will get to the uterine artery. But if you want to separate the rectum, then you have to dissect the medial pararectal space, and in this medial pararectal space there is one more structure which you have to know, and that is called as the inferior hypogastric nerve. So this inferior hypogastric nerve, I will just put the label over here, IHN for short, inferior hypogastric nerve. This runs medial to the surface of the rectum. So it lies just next to the rectum, but it is located at a deeper level and a little bit posteriorly. So you have to actually go in and find the inferior hypogastric nerve. But this inferior hypogastric nerve is important because accidentally if you cut the inferior hypogastric nerve, then it can cause a problem to the patient in terms of voiding difficulties and some vaginal lubrication issues as well. Now there are two inferior hypogastric nerves, so usually even if one gets damaged, the other takes over its course. But if you are doing surgery for bilateral severe endometriosis, then it is generally recommended that because you should not damage both of these nerves together, you must operate only on one side if there is a very severe disease and leave the inferior hypogastric nerve untouched on the other side. Alternatively, the surgery which is done now is called nerve sparing surgery, and if you can definitely isolate these nerves while doing the dissection, then that is definitely more beneficial for the patient rather than injuring them during the surgery. In the last part, the inferior hypogastric nerve leaves from the same place as the ureter is going to leave, which is the tunnel of Wertheim's, which we talked about before, and therefore while doing the dissection of this part, we have to be careful of the ureter as well as this nerve which is going to go from here, and finally it is going to go and come out around the bladder, close to the anterior fornix, through the last space, which we are not going to discuss in detail because that is very rarely required even for advanced surgeons, except for those who are doing high volume CA cervix surgery, which is called as the Yabuki space. So those of you who are interested can read about the Yabuki space. Again, I refer to Dr. Puntambeka's textbook, where all this is described very much in detail, much more than what I have described now. So I hope you liked this video and it has given you some understanding and linking into the structures which are there in the retroperitoneum and where exactly you have to be careful while doing the dissection, so that you stay away from injury and you can dissect the structures out safely without fear of doing them any harm. Thank you very much for listening.